Okay, yeah, I was I get to work next. I'm starting to what? Yeah, and if we have
You're welcome to borrow some. I have dry hands too. That would have been a little weird.
Yeah, exactly. Yeah, it really is.
Alrighty then, let's go ahead and get rolling. Also, riveting stuff to talk about tonight. Get you all ready for an exam or something. Okay, let's finish up Unit 2. I hope I posted the new outline late. It was today, but probably late for some of you. So I have the first page for that. We won't get past that tonight. So if any of you would like to have that, I have plenty of copies. We'll do that when we get to it. I think we're on the bottom of page or top 4? No, 5. Let's not memorize this whole list, but let's take away some really important stuff from it, of this tumor causes and association list. Oncogene, by definition, an oncogene tells your cells to grow. Okay, these literally are proteins coded for by genes whose message to other cells is grow. That there's a point to this. When my kidney first started developing, there needed to be a message telling all the cells, grow. We need you to get bigger. You got to be a kidney, not a little teeny little thing. So that's what oncogenes are for. In certain tissues, these proteins are released, telling that tissue you need to grow and proliferate and, become an actual human lung or kidney. And then there's these other genes called tumor suppressor genes that tell your tissues stop growing. Like when the oncogenes told your kidney to grow, and I'll try to draw like a to scale human kidney, and it got to be about that big, the tumor suppressor gene proteins now came out and said, okay, good, stop growing. So there were proteins telling this organ to grow until it got to a certain size, and then the stop growing genes started saying stop growing. And in a healthy individual, this is how our organs and tissues reach their expected size. The problem can happen in two ways. An oncogene can be never turned off. Then what would happen there? If the oncogenes in my kidney were never turned off, would my kidney have ever stopped growing? No, because that's what those genes are. But what if the tumor suppressor genes were never turned on? Same story? Yeah, and these are two types of genetic cancers. Are when a mutation affects an oncogene, that oncogene tells tissue to grow, and then when that oncogene is told, okay, you need to shut up now, the oncogene says, I'm not shutting up, I'm going to keep growing, and that causes cancer in that organ. On the other hand, if the oncogenes here were normal, but the tumor suppressor genes were defective, there would be no message to tell your kidney when to stop growing. So it would grow and grow and grow, and that basically by definition is cancer. So some of these that I've got on the list are oncogenes that are associated with cancers. I don't know that you've ever heard of any of those, but then on the tumor suppressor genes, the last one there, I could actually add one to this. Which one could I add? I've got BRCA1. Which one can I add? BRCA2. Yes, these are the ones that if you have both, there's like a 90% chance you're going to get metastatic breast cancer. So what do they recommend some women do before they even have cancer? Yeah, double, in some cases, double mastectomy if you have what they call the two hits. If you have one of, I think BRCA1 is the one that's like a 65% chance, and BRCA2 alone is like a 40% chance. I don't know if those numbers are right, but they're probably ballpark. Okay, so I definitely want you to know that tumor suppressor gene example. First, know that it is a tumor suppressor gene, and that if you have a mutation on that gene, you're likely to have breast cancer. The other tumor suppressor gene that I want you all to know is APC. And we've learned this, have we talked about FAP and APC before? They have really long names. This is the genetic colon cancer. People who get, literally, their colon is virtually useless with polyps by age 20. And then it has to be removed before age 25, or it'll all be cancer and they'll die from it. Most healthy people are, I think, still recommended to have their first colonoscopy at age 50. Is that right? Okay, so if we're not worried about your colon for some reason, we can wait till you're 50 to start screening for colon cancer. This mutation on this tumor suppressor gene, they have to have their first colonoscopy in middle school. The oncogene that I like is the BCR-ABL, BCR-ABL, which is the Philadelphia chromosome. I called it the Philly chromosome just so I didn't bleed onto another line. But some people call Philadelphia Philly or Cincinnati Cincy, so it works. I'll probably say Philadelphia chromosome on the exam, so you might just in case. Chronic myelogenous leukemia, or CML, is what this is associated with. It's actually associated with another leukemia also, but this is its most common association. And this is the second worst leukemia to get. Of the four main classes of leukemia, CML is the second worst. AML is the worst. CML, and by worst I mean prognosis. Some of these patients do okay, but others die from it. Okay, so be able to define the difference between oncogene and tumor suppressor gene. If I say describe the scenario, know which gene is doing what. Know, if I ask you about BCR-ABL, know the disease it's associated with, and that it is an oncogene. And for the APC and breast cancer ones, by the way, just so you all know, adenomatous polyposis coli. If I write these out on the exam, I'll give you the parentheses at the end. These are a little bit ridiculous. Familial adenomatous polyposis. I've got writer's cramp now. I hope that's readable. Familial adenomatous polyposis is the second one. Polyposis, many polyps, a few of which will become cancer. By the way, that's what they're lopping out in colonoscopies and stuff usually. They do a screening colonoscopy. It's not just cancer or not cancer. No cancer, that's just going out. They will biopsy any lesion that looks polypoid, because most cancers rise out of a polypoid, a polyp. Little polyps sticking up off of your colon epithelium. Most cancers arise out of a polyp. How many polyps become colon cancer? Less than 10%. Okay, so, but when they do a colonoscopy, if they find 5 of these, they're going to lop out every single one of them, send every single one of them to a pathologist with a little note on the jar that says where in the colon they got them, and the pathologist looks at them under the microscope. In case one of them is cancer, the clinician needs to know where to go back and look for more possible lesions. But what you're hoping for is they're all benign polyps, and that's what over 90% of colon polyps are. They're benign. Some of them are showing to be the early changes of cancer. We call those dysplastic polyps, and the word dysplasia we learned in Unit 1 as always being pathologic. It is a precursor to cancer in a lot of your tissues. Okay? Anywho, stick with those two tumor suppressor genes, one oncogene, know the definitions, and let's move on to some associations. A couple of these you all already know. These are infectious and environmental causes of cancer. Certain viruses, bacteria, or other exposures that we know are associated with certain cancers. I know that I haven't asked you to know much about hepatitis B and hepatitis C virus, and I won't add that yet. We're going to talk about them in the digestive tract. But for now, you should know that hepatitis B and hepatitis C are both associated with hepatocellular carcinoma. It's not a high risk, but it's pretty strong in hep C. That's why there was such a move for the cure, which I already forget its name. Human papillomavirus, and this is something you might want to put a star on this row. I'm allowed to ask you this anytime I feel like it. Well, like on an exam. Actually, I can ask you in the halls if I want. I'm your teacher. Human papillomavirus. First of all, we learned this as one of your DNA viruses, so I expect you to know that. I might say, what are we looking for in a pap smear? And your choices are gram-positive coccus, gram-negative rod, DNA virus, RNA virus, fungus. I want you to know well enough to say it's a DNA virus, because that's HPV. You should also know those two subtypes. Also, they're called serotypes, but I call them subtypes, 16 and 18. They are the two aggressive ones. There's about 25 HPVs, I think, maybe 30 by now, I don't know. But these are the two that are associated with cervical dysplasia and cancer. I think, I don't know if I'm accurate in this, but I think like 95% of skin warts are caused by a human papillomavirus, but no skin warts are caused by 16 and 18, by those subtypes. Men get squamous cell carcinoma of the penis by subtypes 16 and 18. I think, gosh, now I'm like, I think it is. Anyway, I'm just asking about cervical, so no cervical. And what's the screening tool? Pap smears. Yeah. That whole story, I want you all to know the basics on. So know those subtypes, or even for future exams. HPV 16 and 18, those are the two aggressive subtypes that we're looking for in pap smears. Let's not worry about those next two until we get to those organ systems, but H. pylori, I definitely want you to know this association. Helicobacter pylori, Helicobacter, not helicopter, Helicobacter pylori is a bacteria. Technically, it is classified as a gram-negative rod. I will not ask you about its gram-negative rod classification. I will ask you about its association with gastric ulcers that may eventually become gastric inflammation that leads to gastric cancer or lymphoma. Okay, so in our cancer association, this one, if I mention something in the stomach on this topic, I'm probably looking for Helicobacter pylori as the cause. Or I guess on the other side of that, if I ask you something about Helicobacter pylori, the answer probably has something to do with the stomach. Okay? Very strong association between this bacteria and ulcers. Like kind of inching close to like 100% of duodenal and gastric ulcers are caused by this bacteria. Back when I started training in pathology, which really wasn't that long ago, it was in the late 90s, they thought about 50%. No, even 50%. And now they're like 95 stomach, 98 duodenum. So it's a little booger. What's a real strong association with smoking? Did you all know that smoking causes lung and throat cancer? Alrighty then. You don't need me. to tell you that. Smoking actually has maybe a hand in a few other cancers, certainly in a risk of a few other cancers. Certainly it's a player in heart disease and non-cancerous disease of the lungs. So smoking is basically our favorite pestilence to talk about. Like, the first thing you ask somebody who says they want to get healthy is, well, do you smoke? Or if they ask you if they want to get unhealthy, well, do you smoke? You can go both ways with that. I personally think alcohol is a bigger pestilence because it's the accepted pestilence now. Smoking used to be accepted 50 years ago, not 100 years ago. What do I know about 100 years ago? What do I really know about 50 years ago? But 50 years ago, most people smoked, and it was acceptable, and you went out to parties, and while they cracked a beer out of the cooler, they had ashtrays all over the place, and everybody smoking cigarettes. Now it's just the beer and the alcohol. The cigarettes have kind of gone from a lot. But it's acceptable, and we all want to do it, so we kind of deny. But drinking is as bad for your body as smoking, and there's a lot of doctors out there who say it's worse, especially because how many people, because of cigarettes, commit crime and domestic abuse and lose their jobs. It's virtually nothing compared to people who that happens due to alcohol. So that's why a lot of people say it's not just a physical ravaging of your body, it's a social ravaging. I don't think I even have, do I have alcohol on this list? I better, after that, I better. Smoking, lung and throat cancer. Let's not worry about ionizing radiation, but let's definitely know that ultraviolet radiation, UV light, it's often called, is associated with skin cancer. That's what all of our SPFs are blocking out when we go out in the sun. I don't know if you all know this, but a lot of truckers who do cross-country trips are recommended either to do most of your driving at night or to put sunscreen on. And it's like not somebody that truckers, they're in the cab of the truck. But if you're going at the right angle and your arm is at the window in the driver's seat, that's hours and hours and hours that you're sitting in sunlight, that skin is in sunlight. And it's, if that's a regular route, day after day after day, and they were picking up a lot of left-sided skin cancers on truckers back in the 80s, and they started recommending them. Another one is a lot of people put on a hat, like James has, a golf hat or something, to go, oh, I'll just cover up with a hat. Golfers and fishermen. And how is that covering your ears? How's that doing there? No, that our ears stick out from under those hats. And what a lot of people, they don't get it. And they put their hat on, they go, no, I'm covered, I don't need any sunscreen. And in North Carolina, where there's a lot of golfing and fishing, these men come in with squamous cell carcinoma on their ears. Every other part of them is fine, but their ears are sticking out in the sun all day while they're fishing or golfing, and that's where they're lopping off the cancers. UV light, it's basically to the point where I've told you all before, bathe in the stuff before you go out into the sun, and if you really want a good tan, then just spend more time in the sun after bathing in the stuff. I know it's gross and stinky and oily, but cancer's worse. Alcohol has a strong association with many, many diseases, but a really strong association with esophageal and liver cancer. Okay? You all knew the liver disease, but liver cancer can evolve out of just an alcoholic liver, not just hepatitis. Asbestos. Are we supposed to be putting asbestos? Are they still running those ads? Meso book. My God, has it been like 20 years? I feel like I was in high school when those ads started. Mesothelioma. This is, if this is your lungs, there's your right lung and there's your left lung. Lung cancer from smoking gets you deep in the airways. Mesothelioma is cancer out here. And it can be really, really, really aggressive and extremely difficult to treat. Just some kind of inflammatory reaction by lungs to inhaled asbestos causes this on the parenchyma or on the outer pleura of the lungs, and it's killed a lot of people. There's still buildings with asbestos in it. Yeah, there are. I mean, there's a lot of old buildings, like lead paint. It's kind of like you can't just take every building down. That takes decades, maybe even centuries, given how many buildings are up. But there are now, every building that has asbestos has to have a warning about it. They have to go in and clear out a certain amount of it before anybody's allowed to occupy that building. Let's not worry about radon. So those ones that I marked, I'll tell you again, the ones I did mention were Epstein-Barr virus, HHV8, which stands for human herpes virus 8, ionizing radiation, and radon. Those are the 4 that I will not hold you responsible for on that list.
What was the third one?
Third one was, what was the third one? Ionizing radiation. And these will mainly be an association game, like maybe in a short answer, I could say what's associated with gastric carcinoma. You're looking to tell me H. pylori, or hepatitis B virus is associated with cancer of the blank liver. Okay, I'm not looking to make that section difficult, but there are associations you want to start kind of learning. Paraneoplastic syndromes, these are kind of weird. This is when a cancer starts secreting stuff like a hormone. And it's not supposed to, and the cancer isn't even in the organ where that hormone normally comes from sometimes. Like small cell carcinoma of the lung can secrete ACTH, ADH, parathyroid hormone. Lung cancer can start secreting these hormones. What does parathyroid hormone do to my blood calcium level? Raises it. It's the hormone that corrects low calcium. But when a lung cancer starts secreting parathyroid hormone, and it's still a mystery as to how, that parathyroid hormone doesn't respond to any feedback. So when your calcium levels get normal, parathyroid hormone is still out there raising them. So what are these people going to have a lot of? Calcium in their blood, good. And what does that lead to? Kidney stones. They have a frequent occurrence of kidney stones. What about a lung cancer that's secreting antidiuretic hormone? What does the antidiuretic hormone tell your kidneys to reabsorb? Water. So you think if you have antidiuretic hormone constantly, whether you're dehydrated or not, that you're going to be a little bloated with water weight and not pee very much? I won't ask you ACTH, that's a very complicated hormone, at least the secretion of cortisol. But how about EPO from a kidney tumor, erythropoietin? What does that tell your bone marrow to make? Red blood cells, yes. This is a medication. It's a real hormone that your kidneys secrete. It's a medication that we give people who can't make their own red cells, either because they have like leukemia or they've been given chemotherapy. Occasionally it's used by bike race cheaters who get on the radio and lie about it later. They lie for 3 years and say everybody else is lying except them, and then they finally like, okay, I was lying. It just makes me so mad. Sorry. Was all that out loud? I'm still not over that. Well, I'll tell you why that made me grouchy. I don't give a you-know-what about bike racers in the cheating on EPO, but what makes me mad is that that's what everybody associates erythropoietin with, because that's where you heard about it. Oh yeah, that's what Lance Armstrong cheated with to win the Tour de France. 99.9% of the EPO that has been put out there, what has it done? Save lives. It saved lives. It's the same with human growth hormone. Human growth hormone won people Nobel Prizes, but because baseball cheaters can cheat with it and hit long homers, that's what we associate it with. A lot of people think human growth hormone is an illegal drug. Human growth hormone saves kids' lives. Like 99% of the human growth hormone out there saves kids' lives. They would otherwise die. And yet it also makes baseball hitters jack a 480 home run more common than others. It gives these medications a bad name. You all are going to see in the hospital how important it is to dose your EPO patients, or they will become anemic and weak and fatigued and pale and cold because they need red cells. And we need to promote red cell growth in their bone marrow. Anywho, kidney cancer can sometimes secrete erythropoietin, so what will these patients have too much of in their blood? Red cells, yeah, they literally have erythrocytosis. And you know how you treat it until you can fix kidney cancer? You suck out red cells. It's like they're donating blood that can't be given to anybody. I know, it's kind of crazy. And I don't need you to know about serotonin. What I would ask in a question like that is not what type of cancer is secreting it. I might give you a patient that has cancer and then another symptom, like kidney stones, or erythrocytosis, or hasn't urined. I'll word it a different way. That was kind of weird. Yes, that is how I'd ask it. I want you to be able to tell me what hormone is likely being secreted by that cancer. Good? Clear on that list? We've done chemo, we've done miscellaneous terms, so we're on the big finish. That's the top of page 6. And this is about the stress response. Some review here, hopefully. Autonomic nervous system. Autonomic nervous system. I like that the word sounds a little bit like automatic, because this is your automatic nervous system. Is the autonomic nervous system motor, sensory, or both? It's doing stuff. Motor. Your autonomic nervous system is motor. The two branches are always the only two branches, and you all have heard of them, the sympathetic nervous system and the parasympathetic nervous system. What does the sympathetic nervous system do to my pupils? Dilate. What about my heart rate? Increases. What about my respiratory diameter? Meaning airway. Opens it, dilates it. And finally, what does it do to my digestive tract? It turns everything off. Okay? And the parasympathetic nervous system? The opposite of all of those. It constricts the pupils, slows the heart. The other thing I said about the airway, it narrows the airway. It doesn't close it. It just narrows it. And then it turns on everything digestive. That's what we call it, the rest and digest. First thing to know is those organ effects. I won't ask you any additional organ effects than those, and I think that you might want to change something in your handout that I keep forgetting to change. It's not respiration rate that is really affected here. On the last row of each, sympathetic nervous system increases heart rate and change respiration rate to bronchial diameter or airway diameter. It causes what we call a bronchodilation. It increases pupil diameter. I won't ask you about the hair erection, but like goosebumps, if you've ever really been scared, goosebumps are kind of a sympathetic nervous system response. And finally, inhibits everything digestive. That means salivating, stomach acid, peristalsis, that's the muscle movement, just kind of keeping everything going in one way. All that is kind of turned off by the sympathetic nervous system. Because sympathetic is fight or flight. This can be an emergency. If you're a squirrel and you see an acorn and you're really hungry and you're like, oh my God, there's an acorn. I can't believe the other squirrels missed that. And you're almost to the acorn and you see this hawk swoop down right for you. What's more important, the acorn or getting away from the hawk? I don't care how hungry you are. The goal is to see another day. And at that moment, the squirrel needs to disregard the acorn and turn on a full-on fight or flight response. And think about how these things would help. Would an increased heart rate help that squirrel? When you're about to work hard, or say you're going to go run a sprint, you want your heart rate up. Airway diameter. Do we want more oxygen coming in to make ATP? Do we want pupils wide to see escape routes? Because I doubt, it's fight or flight, I doubt the squirrel's going to turn and say, come on, hawk. You ever meet a squirrel like that? Stay away. Stay away. That's exactly the squirrel you should be afraid of. Hair erection. What would that do? Yeah, that squirrel maybe poof up and say, I'm too big for you to eat. That's a defense mechanism, In two more equally matched animals, it's I'm too big for you to fight. Like two cats that are about to get in a fight, they all poof out. Everybody who has cats knows exactly what I'm talking about, and it's freakish. I'm like, oh my God, you're a different cat. Like, you're this big now. But in eating, not an emergency at that moment. If you might die in this situation, have you all ever heard that people who get shot soil their underwear? Okay, that's not entirely true. It's people who know they're about to get shot and then get shot, poop their underwear. A lot of people get shot and they don't see it coming. They don't poop their underwear. Or soil. But if you think you might be about to die, somebody is pointing a gun at you, your sympathetic nervous system sometimes turns off the digestive tract so hard that if there's any poopy in the vault, it gets squirted out because you're that scared. If you don't know it's about to, sorry for this, that was unnecessary after dinner. But that's where the soiling of the underwear comes from. But a lot of people, when they, and a lot of people say, oh yeah, when you die, you soil your underwear, so don't worry about putting on clean underwear. First of all, don't always put on clean underwear. But they say that people soil their underwear. A lot of people die and they don't know 1 second before that they're going to die. So there's no chance for the sympathetic nervous system to kick in, like a car accident. If you're T-boned and you never saw it coming and you're killed in that accident, you're not likely to soil your underwear. But when you think it might, like I bet I told you all, I didn't tell you all, my plane crash friend, he wasn't in a plane crash, but they were afraid there was going to be a plane crash. He was on a Delta Airlines flight from just a short one, Cincinnati, Kansas City. And they took off from Cincinnati, and they told them literally like 20 minutes in the air, they said, we've lost an engine, and we're afraid we're going to lose another engine, so we're going to have the stewardess staff show you how to take the crash position, and we're going to try to turn around back to Cincinnati, but just in case, we want you all to know how to be safe in case the plane goes down. And of course, there's panic in the whole plane. I mean, I'd be leading the panic. And they went through that and they made it back to Cincinnati and offered them another flight, and everybody said, we'll take a car, thanks. Kansas City isn't that far. But after all this happened, my friend kind of was relaying this to me. His name was Sam, and I remember he said, boy, it was just a harrowing experience, Jeff. I mean, I'll tell you, I shit my pants. And I said, Sam, well, I bet. Who would? He's like, no. I literally pooped my pants, and like he said, half the people were going into the bathroom to throw out their underwear because for that amount of time in the airplane they thought they might die, and that's the time to initiate a panic, a sympathetic fight or flight response that makes you just kind of, shoot out what's in the vault and then get in the crash position, I guess. Glad I wasn't on that flight, and that was, let's get back to the handout. You do not need to know where the sympathetic nervous system arises. Anybody traveling this weekend? You do not. I will ask you to know where the parasympathetic arises from, but the sympathetic, you do not need to know where it arises from. You do need to know the two main neurotransmitters, epi and norepi, epinephrine and norepinephrine. If somebody had a severe peanut allergy and they came to your house for dinner and you didn't know they had a peanut allergy and you made one of those, I don't know, salads with like the Sutton nut oil dressing, and you're like, put a lot of nuts in that dressing, and they didn't know it, and they ate it, and they go into anaphylaxis. What are you hoping they have in their an EpiPen? And so what we just discussed about the sympathetic nervous system, that should make sense. Because in a severe anaphylactic reaction, you get a lot of fluids that will close up your airway. What does the EpiPen do? Opens it up. It's basically an injection of the sympathetic nervous system that will dilate all the airways, hopefully enough that they can breathe. Also, when you go through that, your heart it beats too fast but not effectively. An EpiPen will kind of reset your heartbeat so that blood is actually pumping. Actually, I'll get to that in a second. Alpha and beta receptors are the main receptors of the sympathetic nervous system. What this means is when epi and norepi are being secreted, these are the receptors that recognize them on all of your organs. And in fact, you all probably know the name of a beta receptor stimulant that a lot of asthmatics have on hand. Begins with an A, albuterol, and that's what the puffer usually is. It's a quick stimulus of beta receptors. Those are sympathetic nervous system receptors. Stimulating those in the lung will dilate the airway. So know those neurotransmitters and those receptors, and know that that language, agonist, if I ever say a beta receptor agonist, that means something that stimulates a beta receptor, activates it, turns it on. Whereas an antagonist, a beta receptor antagonist, turns it off. You all have probably heard of beta blockers. Do I want to give somebody with asthma a beta blocker? No, that would block the ability of the airways to dilate. But who might I give a beta blocker to? What are they usually prescribed for? Hypertension. So the sympathetic effect on the heart, harder and faster rate. If I could slow that down, would that lower blood pressure? That's why beta blockers are, I think, the second or third most commonly utilized high blood pressure medication. Fluid pills are the most common. They try to just lower your blood volume by getting you to pee off a lot of your water. But if that doesn't work effectively, they oftentimes will add a beta blocker on top of that. Know those neurotransmitters, receptors, and those organ effects. For the parasympathetic nervous system, also known as rest and digest, the opposite of fight or flight. Its organ effects are to lower heart rate, narrow the airways a little bit, constrict the pupils to an extent, and also turning on everything digestive tract. Like your parasympathetic, if I ever ask you what nervous system causes anything in your digestive tract, the answer is parasympathetic. From saliving to pooping and everything in between. Stomach acid, bile secretion. It even tells the pancreas to pour insulin into the blood to tell your cells to use all the carbohydrates you're eating. Very, very important system when it comes to the digestive tract. You should know those 4 cranial nerves it arises from, numbers and names, but that's not a problem because you've all already relearned all the numbers and names, right? Or will have by Tuesday. Good, that's the one. Darn it. Christian, I was going to ask you to come up and do this part. What's 1? Olfactory. What does that do? Smelling. What's 2? What does that do? Vision. What's 3? Oculomotor. What is that? Eye movements, like moving your eyes. But you also see cranial nerve 3 on me. Is that so what do you think it does for the parasympathetic nervous system? Pupil constriction. Excellent. Cranial nerve 4. Trochlear. What does it do? Eye movements. Good. 3 of them are eye movements. 3, 4, and 6 are all eye movements. What's 5? Trigeminal. Think face sensation. If you've ever gone to the doctor and they ask you to close your eyes and tell you, are they touching you with something soft or hard? Soft or hard? Soft or hard? They're testing your trigeminal nerve. How well your face senses the difference between, say, a warm fuzzy touching it and a sharp prickle touching it. They literally, you will see them do these exams. 6 is abducens, eye movements. 7, facial for face motor, stuff you do. Face expression, that's good. Google Bobby Knight's press conference face expressions. You'll see how basketball coaches use it. Anyway, what else? 7 is also on our list. It is really important for salivation, the facial nerve. Remember, that's also parasympathetic nervous system. 8, vestibulocochlear. I would never ask you to write that out. I might ask you, what is the vestibulocochlear nerve for, or what is cranial nerve 8 for? What is it mainly for?
Hearing and balance.
Hearing and balance. And are those two tied in? Very, very much so. If you ever have an ear infection that affects your hearing even on just one side of your body, it can cause you tremendous dizziness, disorientation, loss of balance. Okay? Cranial nerve 9. Glossopharyngeal. Good. Anybody struggling with that? Tongue, throat. That's what that means. Gloss is tongue, pharynx is throat. And that's where that nerve works. It helps you taste. It helps you salivate. It helps you swallow. It's a really, really important nerve. When we check the gag reflex, we're checking the glossopharyngeal nerve. Cranial nerve 10. Who said vagus before? There you go. What does vagus do? That's good. I like what Callie just said. I like what you all were trying to do. But let's just say it basically does everything. I'm not sure there's a more important nerve in your body. It is the one that literally comes from your brainstem and goes down to your organs, slowing heart rate, narrowing diameter, telling the pancreas to shoot out insulin. It does all the parasympathetic nervous system in the upper 2/3 of your body. And 11? Accessory. If I ever wanted to ask you what the accessory does, it would be shrugging shoulders. And that's how we check it. And finally, 12, hypoglossal. Where is that located? Hypoglossal. Where is it located? Under the tongue. Under the tongue. And what does it do? Tongue movements. You know how you test it? Yeah, you ask a patient to stick their tongue out straight. And if they go, you say, stick your tongue out straight again. And they go, there's something wrong with that. I know, it's not always, first of all, it doesn't make sound. It doesn't usually make that sound. But they probably have a problem with the hypoglossal nerve. I'm emphasizing these. I'll tell you what, on this exam, let's stick with names and numbers, not functions, but I do want you to know the 4 that give rise to the parasympathetic nervous system. Literally, I might say which of these is not a parasympathetic nerve. I'll list these 4 with another cranial nerve, be able to pick it out. These are so important, though. You all already know this, even if you just watch TV. If I have an unconscious patient and I want to assess, could they just be unconscious because they bumped their head? Or are we talking about a severe central nervous system injury? I can even assess that on an unconscious patient with a light. How do I do that? Yeah, I lift their eyelids and shine the light in their left eye, say. What should their left pupil do? Not dilate, constrict. The more light, it should constrict. And now, what should the right eye do while I'm shining the light through the left eye? Also constrict. It's supposed to sense that there's light in the left eye, so this pupil will constrict too. If that occurs, you can, looks like the brainstem is okay. Well, you just check the pupil, so we haven't done the tongue thing yet. But really, that's what a cranial nerve exam is. You will learn to do it in a matter of a couple of minutes to assess all 12 cranial nerves, and hopefully, if it comes out normal, you feel comfortable that their central nervous system is intact. You can start dealing with less imminent concerns that's causing the symptoms. Okay? It's just so high yield. You can do something in literally minutes that gives you, it rules out a lot of serious stuff. And oh, by the way, if their pupil is blown, now you're freaking a little bit. They could have an advancing bleed in their head. You need to send them for a CT scan. You need to basically call everybody that outranks you to that site and hope one of them takes over. That's what I used to do. Oh, you outrank me. It's scary. Dealing with that stuff is scary. Okay, I will not ask you about the neurotransmitters or the receptors for the parasympathetic, since we're going to learn the nerves that give rise. So you don't need to worry about acetylcholine being the main neurotransmitter of the parasympathetic nervous system. You do not need to worry about M and N receptors, they're actually called muscarinic and nicotinic. I will not ask you about those. organ effects and its origins. Cranial nerves 3, 7, 9, and 10. Finally, to tie off Unit 2 here, is a discussion on cortisol, which, let's orient ourselves. Let's just do a quick, here's a rough sketch of an adrenal gland. And there's cortex, that's the outer, and then this inner kind of mushy part is the medulla. Okay? Anybody remember all those cortex layers? Glomerulosa, fasciculata, reticularis. Don't worry, I'm not going to ask you those. Okay? But you may recall one of them is primarily responsible for secreting aldosterone. We've talked a little bit about aldosterone in this class. Then this layer is primarily responsible for secreting cortisol. What's the medulla primarily responsible for secreting? Epi and norepi. This is basically, can fight or flight be an emergency? And so the sympathetic nervous system isn't only a nervous system, it has access to your blood. When that squirrel saw the shark swooping down at it, that's about as emergency as, what did I say? Well, the squirrel could be swimming. It could be spring break in Florida. Hawk. Okay. What swoops? A hawk? Okay, so the moment the squirrel sees that, or I guess I could have said, I see a shark. That would have made sense, because I'm going to have the sympathetic response. The moment that squirrel sees that hawk, it doesn't get any more imminent and potentially life-threatening than that. At that point, to have the most effective adrenaline or fight or flight response, basically your adrenal medulla starts pouring this stuff into your blood. All the nerves that can shoot it out are shooting it out on other nerves, but it's also pouring into your blood. I don't know that I've ever been legitimately scared, literally to the point of thinking I'm going to die. Got mugged in Westport once in college, and my friend wanted to fight back, and these guys were gigantic, and I knew if my friend tried to fight back, they'd just crush us. That scared the you-know-what out of me. But it was like for 2 minutes. They got our wallets, they were gone, and I'm just holding my friend had just started taking karate, so he thought he was some kind of Jason Bourne. I'm like, dude, don't even. It wasn't 2 minutes. Nothing happened. But for 20 minutes after that incident, where I thought maybe for a second we could get hurt, my chest was echoing with my heartbeat. I just heard boom, 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 boom. So I think I kind of had a sympathetic nervous system response. That's what this does when you have a true adrenaline response. Maybe those people in my friend's airplane situation, they were told, we might crash, so here's how you stick your head between your legs and maybe survive. One of you might survive, kind of thing. That would scare a bunch of people. It's pouring out of here. That is basically your sympathetic nervous system's access to your blood. But this is about cortisol, this little section. Cortisol is one of the most confusing hormones to understand, so I try to keep it simple. A lot of people call cortisol the sugar hormone. I've got a problem with that. What do you all want to call the sugar hormone? Well, glucose is sugar. Insulin is the sugar hormone to me because it's the one that is secreted after you eat for about an hour. It circulates and tells all your cells to use the glucose to make some energy. Okay? Cortisol, here's what it does. When it's secreted, it circulates in your blood until it's basically convinced there will be an emergency and that we will need the brain to think us out of this emergency. So its message is, nobody but the brain is allowed to use the glucose. Don't use glucose. Don't use glucose. Are you the brain? I didn't think so. Don't use glucose. Save it for the brain. The almighty brain will save us when there's an emergency. So I like to call it the sugar and stress hormone. Because, yeah, it does talk about glucose management, but it's like paranoid all the time. There's going to be a problem. There's going to be a problem. So we better have glucose for the brain. Anytime we have a problem, the brain thinks us out of it, so let the brain have the glucose. So if the brain isn't really using the glucose, what happens to glucose levels in my blood? They go up because everyone's like, okay, don't use the glucose, let the fancy brain and load the glucose. It's kind of what all the other cells are doing. That's the message they got. So you can actually see what I've listed as glucose intolerance. It gives a false fear of diabetes. It makes patients look like they are not able to manage their glucose when in fact it's the cortisol that's doing this. It suppresses your Th1 helper cell response. Does anybody remember what branch of immunity that is? Cell-mediated immunity. Good, that was that top branch I did. And it promotes the Th2 response. Which one was that? Humoral, good. Antibody production. So if you ever heard of steroid treatment, when I give somebody, say, prednisone, I'm giving them something that's like this. And what we usually give people prednisone for is to turn off their cell-mediated immunity because they have some bronchitis. Or maybe I've given them a kidney transplant, and prednisone is one of the anti-rejection medications we give. Do some people take steroids without a doctor's prescription? And what are they looking for? Yes, they're looking to be better athletes and bigger muscles. Okay. If you cycle your cortisol, you will have a lot of glucose for energy when you work out. That's the ideology behind that. But here's the problem with taking steroids, and it was a real pestilence in the high school age kids for a while. I don't know if it still is, but I don't know, maybe 10, 15 years ago, they were calling it a national emergency with all these kids because they were ignorant. They didn't know any better. You know how we all are when we're 16, we're invincible. And if your friend is on steroids, you're on steroids, and you don't really realize it might make you sterile. It might give you a mood disorder. But the problem with taking a lot of steroids is if I give my body stuff that looks like this, the message to my adrenal gland is, well, I guess you don't need me anymore. If you're putting the steroids in, I guess you don't need me anymore. So this layer of your adrenal gland will literally shrink, like it's getting depressed and withering away. And then when you stop taking steroids, it doesn't grow back. And this layer in young people is for the sex hormone precursors, estrogen and testosterone. And this is exactly why men have problems after taking steroids for a long time at a young age. Now they have sterility issues, they have basically manhood issues, and that leads to a lot of problems. So, but it's all because they're taking something that looks like this and basically telling their adrenal cortex, I don't need you anymore. So it will shrivel up and go away. Know the Th1 and Th2 response, know the glucose intolerance on cortisol, and definitely know where cortisol comes from, specifically the adrenal cortex. That's the outer part of the adrenal gland. Any questions on Unit 2 to this point? Did we cover everything in that outline? Did I miss anything? Would you tell me if I did? Have we done the metric prefixes? Yeah, did we do that on the last test? How'd it go? So we're going to do it on this test too? Is that how it went? I don't remember being that upset, but I remember, didn't I make a comment about it, that there was a real low number of you that got both of them right? Like three of you or 4 of you that got both of them right. I've asked you to know 6 metric prefixes. Did I ever draw my line and show you how to use it? That is all you need to make this work, as long as when you draw the line, don't just do a dash for the ones I've asked you to learn. Okay, do all your dashes, 1, 2, big, 1, 2, big, 1, 2, big, however far out you want to go. And then 1, 2, big dash, 1, 2, big dash, 1, 2, big dash. Then label your big dashes. I've asked you to know, I think, 3 of those or 4 or something. I've asked you to know kilo, mega, milli, and micro. There's only 2 others I've asked you to know, that's deci and centi. So now the game is, if you don't struggle with this, you may tune me out for the next minute, because I don't want to confuse anybody that already has their system. But if you do struggle with this, this is the only tool you need. It is a perfect tool. Kind of like when you have a flathead screw you need to remove. What's the perfect tool? Is it a Phillips head screwdriver? Hammer? Chisel? Power drill? I'm trying to think of stuff. I'm not really a tool guy. Flathead screwdriver? That sounds about right. Perfect tool for this. I can give you any of these and ask you to convert it to the other, but if you use this and I give you centimeters, 58 centimeters, and ask you how many kilometers that is, by using this tool, you know that you have to move the decimal to the left, because kilometer is to the left of centimeter, and you need to move it 1, 2, 3, 4, 5 spaces to the left. And if I started with 58, is my decimal here? No, my decimal is here. And if I want to move 5 spaces to the left, I start there, put my decimal, fill my waves with zeros there, and that's how many kilometers 58 centimeters is. Here's 58 centimeters, right? About 58 centimeters. Can I even fit 1 kilometer in that? So does this answer make sense? It's a tiny number. Yeah, it's a small fraction of a kilometer. If I would have said 58 kilometers is how many centimeters, now I've given you this one. Which way am I going to move my decimal? How many spaces? 1, 2, 3, 4, 5. We start at the same place. Zeros over every wave, a comma every 3 spaces. So now 5.8 million, or 5,800,000 centimeters fit in 58 kilometers. And that should make sense, because 58 kilometers is like from here to Emporia, or something. Sound like about 5,800,000 centimeters. I've never really counted it to check, but I'll take it. Okay, 1 or 2 questions on this. I want you all to start feeling comfortable with these, not annoyed by them. And again, you don't need me to tell you why. You can ask your classmates who are in nursing school why. Because they probably look at this and say, boy, I wish that's all I had to do the first week in nursing school, rather than convert 76 pounds per square inch into kilograms per square millimeter. And if you don't know these, this is a seemingly invincible problem. But if you feel comfortable with these, this becomes comfortable. And in fact, this problem is just multiplying by 1 twice. That's how you do it. Multiply by 1 twice. It's just that 1 has some really crazy outfits in its closet. Yeah, like, is that right? That's the number 1. Ooh, I should have flipped it though for this problem. Anyway. Okay, I'm not going to ask you this. Questions? I just wanted to make sure to say that. Do you all know the meninges in order? Do you know what the meninges are? Yeah. Lele, did you say yeah? DAP? Did you just say DAP? That's a great way to remember it. Dura, arachnoid, pia. I think it's if I ask you that. Do you all remember the little bile story in the hepatic portal vein? Hepatic portal vein, digestive tract and spleen to the liver. Where do all the other veins you know of go? To the heart. So this is the exception. It doesn't go to the heart. Am I going to give you the heart as a choice? Yeah. Of course I'm going to give you the heart as a choice. I want to try to trick you. But if I ask you about the hepatic portal vein, digestive tract and spleen to the liver. It will eventually get to the heart from the liver. Heart. What chamber receives blood from the superior and inferior vena cava? Right atrium. I heard that in pretty good stereo. And what valve is it about to cross? Tricuspid. Good. What chamber does blood arrive from the pulmonary veins? Left atrium. Atria are your arrival rooms. Ventricles are your leaving rooms. So the right ventricle, blood leaves to where? Pulmonary trunk to the pulmonary arteries. How many lungs do I have? 2. Well, the only reason that's a little bit confusing is the road out, it's one road, it's one highway. But then the pulmonary trunk just needs to split into a right and a left road for each lung. Is that blood well or poorly oxygenated? Poorly. That's the whole point of sending it to the lung. As soon as that click goes on in your head that the right side of the heart is receiving used blood and sending it to the lungs to get oxygen, and the left side of the heart is distributing the good stuff, sounds a little weird if somebody was just walking by, but distributing the good stuff, that starts to make everything make sense. And those veins and artery in the pulmonary circuit, if you just know your veins and arteries in the systemic circuit, and then remember, if it begins with the word pulmonary, it's backwards. Arteries don't have high oxygen, veins do. But the bottom line is, by now, you all want to start understanding the flow of blood through the heart a little bit better, because when we start talking about conditions and pathology of the heart, what we do and what the patient experiences doesn't make sense to you if you don't get the normal flow of blood through the heart. So again, little stuff like big vessels, chambers, and valves is fair game for this exam. Again, a couple of questions. And I probably will do 3 or 4 questions on that white cell list on the first page. Phagocytes, which one is in pus, which ones are specific. A lot of basic questions. There will definitely be a question about all the stuff that mast cells secrete. It will be multiple choice. I'm not going to ask you to write out leukotrienes and stuff like that. I can barely write that stuff out. But I want you to be able to pick out an imposter. Okay, and I'm trying to think of the cranial nerves, name and number, 1 or 2 questions. And I'm going to pick pretty straightforward ones. Like, I might say, the vagus nerve is also known as blank, and I list cranial nerve 2, cranial 4, cranial nerve 6. Which one do I have to put on there? 10. Or I better have the answer, none of the above, yeah. Oh, that's right, this class doesn't like these questions either. I did that to my A&P group, they're a little pissed. They're a little grouchy at me over the weekend. I did that. Did any of you, I had an A&P, remember that question I asked you which of these is true? And there's a selection that says the typical human body has 12 thoracic vertebrae and 4 quadriceps. Does that sound right? 12 thoracic vertebrae? 7, 12, 5? Ooh, should I ask this on the exam? Oh, no. Come on, people, you know this. How many cervical vertebrae?
7.
How many thoracic? How many lumbar? How do you remember that? Yeah, breakfast at 7, lunch at noon, early bird dinner at 5, kind of thing. I know, I wish it was 6. I won't ask you that. But forget about my A&P class. Let's just stick with your test. You're trying to figure out why it's not true?
No, she did that with the G. I did that with the genetic disorders.
Oh, yeah. Numbers in biology. I'll get you. What else did I tell you would be fair game for this exam? I think I'm just going to stick with the handout for the rest of it. Okay, know those hypersensitivities and those associations I gave you? Like I might just say lupus is a blank and I list 4 hypersensitivity. Type 1, type 2, type 3, type 4. Be able to pick lupus out as our type 3. Okay, there will be a couple questions on blood typing and like give you a patient's type and can I give them this plasma or those cells or what? Okay, I'll stick with ABO on those questions. ABO only. There's no such thing as an AB antigen. You all understand that, right? There's an A and a B. That's what makes type AB blood. And about 40 multiple choice questions, 40, 45, and the rest short answer. Just like last time. About right? Do we have this exam scheduled for Tuesday?
Yes.
And I think that we're about the same breakdown, so how about M through Z is in this room. And I just have to play it safe. That CNA class, they told me it was over, but they were down in our room last Tuesday night, so I don't want to take a chance. I'm going to put A through L right below us in room 120. Just right downstairs. It's a regular classroom downstairs. Janice will be our proctor. Say again? The old A&P room, yep. Who needs a page 1 for the Unit 3 handout? Let's just do a little bit of this. There's no reason. I know you all want to get home and start studying for this exam. Say that again? A through L is in 120. Yes, last name, sorry. A through L, last names, first part of hyphenated last names. Who else? Okay. Thank you.
It's always tiny.
All right, Unit 3. It's nervous and endocrine. It's like our A&P unit. This is an 8-page handout. I'm going to take a couple of sections out. I know this is long, and a lot of it is going to be kind of arduous, but I don't think it's going to be hard to understand. I'm not going to get into a lot of pathophysiology. It's just knowing features that distinguish certain conditions. Let's start by reviewing our normal nervous system, starting with the basics: central nervous system versus peripheral nervous system. One important difference: central nervous system, motor and sensory are separate, and in the peripheral nervous system they're mixed up. What that means is there are parts of my brain that are specific motor parts, and then other parts that are specific sensory parts. But my nerves out here are mixed. That's why people who have carpal tunnel syndrome, their median nerve is getting squeezed in their wrist, have loss of function, motor symptoms, and pain, throbbing, tingling, sensory symptoms. Separate versus mixed. Sensory pathways are feeling stuff. We also call them ascending. I will not ask you all to know the term afferent, but you may see it down the road. And motor pathways, pathways for doing stuff, are descending, leaving my brain and going down to do something. Autonomic nervous system versus somatic. Somatic means that stuff you're in control of or consciously aware of. Like walking. That's a voluntary or somatic action. You're in control of that. You can stop it when you want. But you're not in control of dilating and constricting your pupils. That's automatic. An example of a somatic sensation would be stepping on a nail. Would most of us feel that if we stepped on the sharp end of a nail? That's a sensation that I'm fully aware of feeling. But if your pH went from 7.39 to 7.40, would you know it? They're both in the normal range. So there's no reason you would know that. Your body would. That's somatic sensation. Or sorry, that's the opposite of somatic sensation. Those are sensations you're not aware of. We won't talk about those. We've already done the sympathetic, parasympathetic in Unit 3. I'll still want you all to know those organ effects. Cells. You will not have to draw me a cell, but you should maybe review a stick neuron and remember how it works. Dendrites are the receiving end, and the synaptic knob is the secreting end. So just drawing this nerve, you all should be able to look at it and say it's going that way. It's conducting that way. Do you know whether it's and here's another one. This shoots out its neurotransmitter onto this nerve's dendrites, and this nerve now conducts this way. Is that a 2-nerve pathway? So you may hear, and is this called a synapse? Where a nerve cell talks to another cell is called a synapse. Most synapses in your body are in one nerve cell to another nerve cell. They never touch. There's always a space. Okay? And we often say this is the presynaptic nerve and this is the postsynaptic nerve in that pathway. Just language. Do you know whether this is sensory or motor yet? Yeah, I haven't oriented you, but if I did this, now what is it? Sensory. It's bringing information towards the brain, not going away from the brain. So sensory is bringing information in. Your nerves are one or the other. The nerve cells in your body are either oriented toward you or away from you. Half of it is nerves coming up to your brain to bring sensory information in. The other half is nerves going out so you can respond to that sensory information. Okay? When one nerve shoots out a neurotransmitter, you can go ahead and assume that that's the only neurotransmitter that nerve ever shoots out. Okay? It's not like this nerve can shoot out dopamine one day and serotonin the next. Okay? That's not how it works. You have serotonin nerve cells, dopamine nerve cells, norepinephrine nerve cells, acetylcholine nerve cells, GABA nerve cells. You get the point. Okay? It's one neurotransmitter. And sometimes a nerve cell is shooting to another nerve not to make it fire, but to turn it off. That's called an inhibitory pathway. So there's a lot of language associated with this. For my neuron section, dendrite, cell body, axon, and synaptic knob, I'm not going to ask you those parts, but I might mention them in a question. I want you to kind of be familiar with what they are. Glial cells, also known as neuroglia, the support cells of the nervous system. I will not ask you to name any of them, but they appear in our tumor section. Probably the important ones, for those of you that like your abbreviations, I'm skipping a lot of abbreviations, sorry, but if I'm not going to hold you responsible, I don't think, to give you all the abbreviations. Here's another name for the sympathetic nervous system, which I will not use in pathophys. It's called the thoracolumbar. And CS is craniosacral. That's another name for the parasympathetic nervous system. I will not hold you to those. A is astrocyte. You all have heard of these. Astrocyte, oligodendrocyte, ependymal cell. What do they make? Ependymal cells. It's a fluid. Cerebrospinal fluid, CSF, yeah. How do we look at that? What do I have to do to a patient to access that? A lumbar puncture or spinal tap? And as you all may remember, well, should remember from your A&P, there's a conveniently located little tub of it. Because of the way my meninges separate, the CSF pools down here in a place called the lumbar cistern. And it's after the spinal cord is ended, so it's a really safe place, not that it feels too good, it's a safe place to poke a needle in and suck out some CSF without hurting any of the nervous system to sample it. Very, bless you, very high yield test in patients who have nervous system issues like infections, tumors, all kinds of stuff. What's the next one? Microglia. Again, I just helping you all with your abbreviations. I'm not going to ask you about these satellite cells and Schwann cells. When I need to ask you about one, I'll mention it. These two are the myelin makers. That's the CSF maker. That seals the blood-brain barrier. Okay, so they're really important support cells of the nervous system, and most cancers of the brain arise out of these. Brain, brainstem, cerebellum. What are the four main lobes of the brain? Good, I heard them all. Frontal, parietal, temporal, occipital. Good. What's the mini brain called? Cerebellum, okay. And then the three levels of the brainstem? Midbrain, pons, medulla oblongata. Again, it's mentioned in the movie Waterboy, for those of you who haven't seen it for a while. Pretty funny. They're arguing about why alligators are so ornery. Mama says it's because, oh, come on, you all have not seen this? Okay. I was given this movie for homework, okay, a few years ago, and I watched it. And it's not that great a movie, okay? I'm sorry. It's just not. It's not. I'm not really an Adam Sandler guy, but I will say that scene was really funny. happens about 40 minutes in, where he argues with his professor about the movie. Well, got it. It's pretty funny. Anywho, you should probably know that. You should review that basic anatomy. Most of your cranial nerves arise out of your brainstem, and that's why I was saying earlier, a cranial nerve exam is a great non-invasive way to assess someone's brainstem if it's been injured. Spinal cord and tracts, don't worry about that stuff. You all remember your nerve pathways, spinal thalamic and posterior columns, hopefully. Let's not go through that journey again. I'm going to go ahead and say that CSF and meninges are really important to understand. I won't ask you these cells, but what structures are CSF made in? Does anybody remember? Rooms in your brain. Ventricles, yeah, you have right and left lateral ventricles, then you have the third ventricle, and then the fourth ventricle right at the top of your brainstem. That's where all of your cerebrospinal fluid is made. And it pours out. It's like, my students never like this comparison, but have you ever seen those parties or weddings where they stack up champagne glasses, this big wide, and then they get really, and then somebody gets on a stool and they start pouring bottles of champagne into the top glass, and it just cascades like a waterfall down all the other glasses. And whenever I'm at those parties, I just walk up and take one from the bottom row and see what. Oh, come on, that's good stuff. That cascading of champagne or non-alcoholic beer, whatever you want, is kind of like CSF. It's made up here, and it just kind of pours out, and it pours a little bit too fast to go down the teeny tunnel down my spinal cord, so it spills over the edges and fills my subarachnoid space, all around my central nervous system. If you ever want a border between central and peripheral, the dura mater is the best border. If anybody ever asks you, where does the central nervous system end? You can say the dura mater, because the meninges cover the brain, the meninges cover the brainstem, and the meninges cover the spinal cord. And in between the arachnoid and pia, it's called the subarachnoid space, you have this CSF fluid. It lubricates, it nourishes, it protects, and it's really, really, really sterile. And a healthy person, if I did a spinal tap, I'd see clear fluid. And if I send it to pathology for them to spin it down and hopefully see some cells sediment, if they're healthy, they should see nothing. There should be nothing in it. Maybe one protein, yeah.
Okay, so I've seen CSF before, we did an adult, it was clear, but we did it on a baby, it was like bronze color.
Okay. And?
I don't know.
Did that worry anybody?
They just told me you just take it downstairs to the lab, and I was like, okay.
What I'm thinking in that case, it might have been a bilirubin thing, and they might have had to do the photolight, the lights where the skin has to activate an enzyme that metabolizes bilirubin. So that could have been, just when you said bronze, I was thinking jaundice.
It looked like it had blood in it.
Okay, now that's another thing, is oftentimes, first of all, if you know you got an adequate spinal tap and you see blood in it, that's a problem. That's an emergency. Sometimes you diagnose a hemorrhage, an intracranial hemorrhage that way. But there's also the possibility that your lumbar puncture procedure actually got into a blood vessel and sucked out blood too. So you want to make sure the person did it is sure they got it. We'll talk about the lumbar punctures a little bit later. There's some people who have an intracranial pressure so high that when they try to do a lumbar puncture, I have not done very many lumbar punctures in my life. I just did it as a medical student. I had to check off the boxes of so many procedures to do. So I never really did one on an acute patient, just patients we were kind of suspicious needed it, because they don't want the pimple-faced medical student around anybody that's that sick. They want the real doctor around that patient. But doctors used to describe to me in a patient with severe meningitis or elevated intracranial pressure, you do a lumbar puncture on them, you push it in and you feel the pitch back. You literally feel the pressure of their CSF try to push your needle out of them. You go, and it kicks back on it. That would be really freaky to feel. But so again, it's very procedural related there. Know that CSF and meninges story. By the way, I always make CSF every day. Where do I get the stuff to make it? Blood. Blood. That's the answer to that question no matter what I ever ask. Where did I get this? My body made it. It got the stuff to make it out of the blood. That's how your body makes bones. Or adjusts bones. They get the stuff out of the blood. Or when your body breaks bones down, where do they put the calcium? In the blood. Yeah, the blood is everything. So I filter the blood to make CSF, and I do it every day. What does that tell you I also have to do? Get rid of the old CSF. That's exactly right. If I'm making it every day, I only have a limited amount of space in me. So there's these things called arachnoid villi. Arachnoid villi. I want you to know that term. Arachnoid villi. What layer of the meninges do you think they're on? They're on the arachnoid layer. Does the arachnoid layer kind of sound like arachnophobia? Which is a fear of what? Spiders. Yeah. You know, that movie, did you all know there was a movie called Arachnophobia? Those weren't scary spiders. They weren't hairy enough. There's a spider in South America that's like this big, and it's all brown fur, and it eats birds and bird eggs. If I saw that thing, I'd drop so quick it would chew my face off. I'd be paralyzed with fear. That's just wrong. A big furry spider. What are you talking about?
When I worked at the school here in town, there's a lady called the Bug Lady. And she has one. She's like, don't worry, he's just a baby. He's 6 months old. And she found out that I was deathly afraid of spiders. And it was this big in a dish, and she put it right next to me.
Oh man, yeah, that's a baby. They have one at the zoo that's a young one, and I'm like, I'm sorry, that thing could take me down. Just it would paralyze me with fear. I could never live in the American Southwest. I have friends down there. They say they come home and there's this giant tarantula in their garage. They literally keep cinder blocks in their garage. They could drop it on them when they see them. And I'm like, well, now that's cruel. That's just cruel. I heard hairy spider and I just stopped listening.
Being bit on the face by a random flu, that's pretty darn scary.
It is, but especially if you're allergic, then you can react to it. Anybody ever seen those camel spiders? Holy cow. Don't ever send me there. Here's what an arachnoid villi is. Does that look like a little spider? It's not a spider. It's a drain. And these are CSF drains. They're on the arachnoid layer. That's actually why we call it the arachnoid, because when they discovered these, they all look like little spiders crawling along the arachnoid mater. But these are CSF drains. Where do I drain old CSF into? The blood. The blood. Okay? Now, here's why this is important. If I get inflamed for some reason in my meninges, now these drains, they get smushed shut. Am I going to be able to drain my CSF? Well, I'm not going to stop making it. Is that a problem? My intracranial pressure is going to go up really, really quick. And this is exactly the problem in meningitis. Inflammation of the meninges can swell these shut. And that's the source of their intracranial pressure. You've got to intervene on that. Cranial nerves 1 through 12, you've got that. Oh, blood supply. Let's just review this. What does this stand for? Circle of Willis. Good. The feeder, it's a little circle, it's like a roundabout of blood flow at the base of your brain, fed by the internal carotid arteries and the basilar artery. And then, you all know what a roundabout is. Like when you're going around, you just exit wherever you want. That's kind of what this is. And these little arteries exit off it, shooting into my brain, bringing blood to my brain. And it's these little arteries off the circle of Willis that when you get a little clot in one of them, now you have a stroke. Branches off of the circle of Willis is where stroke clots form and lodge. And it could be a big one, taking out a whole lobe of the brain, or it could be a teeny weeny tiny one that barely causes maybe some visual changes and you think you just had, I don't know, a bad enchilada or something. That's actually a heart attack. Not the bad enchilada, like indigestion. Yeah.